Hi, my name is Nicholas Harsh. I am currently a student at the University of Toledo in the Pharmacy Division, and I am a PharmD candidate of 2022. So before I start the discussion, I just hope that by the end of it, you will be able to form an opinion based on what I presented to you today, and I hope you learned something. So my article was Nintedanib in Progressive Fibrosing Interstitial Lung Diseases. For the background, PF-ILD, Progressive Fibrosing Interstitial Lung Diseases, they're not one specific disease, but a umbrella term that covers many diseases that fall under ILD as well. So they're a subcategory of ILD, and then PF-ILD has subcategories underneath it as well. And those are various, including autoimmune-associated ILDs, or hypersensitivity pneumonitis, sarcoidosis. And what makes an ILD progressively fibrosing is the progressive phenotype that comes along with it. And in a nutshell, the progressive phenotype is a cycle of fibrosis that is occurring in the lungs. A similar article to this one, carried out in 2019, evaluated the efficacy of nintedanib in systemic sclerosis-associated ILD, and they found that the annual rate of FVC change was statistically significant compared to placebo. The authors of this study, however, the objective was to investigate the efficacy and safety of nintedanib in fibrosing interstitial lung diseases with the progressive phenotype. So their study design was randomized, double-blind, placebo-controlled, parallel group phase 3 trial conducted at 153 sites in 15 different countries. For the inclusion criteria, adults with a physician-diagnosed fibrosing interstitial lung disease, features of fibrosing lung disease affecting more than 10% of their lungs by volume, an FVC of greater than 45% of predicted, and a diffusing capacity for the lungs for carbon monoxide of 30 to less than 80% of predicted. In addition, one of the following had to be present: either a relative decline in FVC of at least 10% of predicted, a relative decline of FVC of 5 to 10% of predicted, and worsening respiratory symptoms, and lastly, an increased extent of fibrosis. And this criteria was required to confirm that the patient's ILD was progressively fibrosing. For exclusion, patients treated with azathioprine, cyclosporin, mycophenolate, tacrolimus, rituximab. There's a few others that I listed there that you can see. And the supplemental appendix also listed a slew of other criteria that excluded patients, including patients with renal and hepatic issues, bleeding risks, CV risk, cardiovascular problems. The primary endpoint was the annual rate of decline in FVC, and this was assessed over a 52-week period, and it was the spirometry measurements were taken at baseline, week 2, 4, 6, 12, 24, 36, and 52. The absolute change from baseline in the total score of the King's Brief Interstitial Lung Disease Questionnaire was a secondary endpoint, and this questionnaire is a self-administered questionnaire in which it measures three different symptoms, including breathlessness, physiological factors, and chest symptoms. Another secondary endpoint was a composite of acute exacerbation of interstitial lung diseases, death, or death alone as assessed during the period until the first database lock. For statistical analyses, randomization was stratified according to imaging patterns. This was to separate the people that had faster fibrosis progression and equally distribute them in between the two groups. Alpha was set at a two-sided 5% level for significance, and sensitivity analyses were performed via a tipping point analysis, where the authors found the point at which result would change from being statistically significant to statistically insignificant. Power was set at 90% to determine, and it was determined by 600 patients, including 2/3 or 400. So if 600 patients were included, then they would have met power of 90%. The baseline characteristics of the two populations were very similar. I included some of the more important ones in my opinion, including the FVC, considering it is the primary endpoint. So the baseline FVC was 69 plus or minus 15.6%, and this was not statistically significant between groups, so that is good, they were similar. For the endpoints, the results, the adjusted rate of decline in the FVC over the 52-week period, the nintedanib group, was a decrease of 80.8 milliliters per year, and the placebo group rate of decline was a decrease of 187.8 milliliters per year. This had a confidence interval of 95%, 65.4 to 148.5, with a p-value of less than 0.001, so statistically significant. Along with this analysis, they also did a separate one for the UIP-like fibrotic pattern patients, as I mentioned earlier, and the adjusted rate of decline was a decrease of 82.9 milliliters per year in the nintedanib group, and a decrease of 211.1 milliliters per year in the placebo group. Once again, statistical significance was shown with a p-value of less than 0.001. For secondary endpoints, there were many. I'm not going to list them all because they were all statistically insignificant. But one of them that stood out to me, that wasn't significant in fact, was the percentage of patients who died over the 52-week period of the trial. It was 4.8% of the nintedanib group and 5.1% of the placebo group, so as you can see, not much of a difference there. Additional analyses that were done, in the nintedanib group, 33.1% of patients experienced an adverse reaction that led to a permanent dose reduction, compared to the 44.2% of the placebo group. Fatal adverse events, however, were less in the nintedanib group versus the placebo group. For the strengths, I have a few here. Appropriate blinding was carried out by the authors. Statistical tests were appropriate, and power was met, as they had more than 600 participants. And the study contained patients of varying subsets of PF-ILD. At first, I was unsure of whether this could be a strength or limitation, and I still believe it could be both. But in my opinion, I think it could go either way, but nintedanib did show effectiveness in a broad range of PF-ILDs, but this could lead to problems as there are PF-ILDs that are more prevalent than others. So if you have one that's more rare that happened to be included in the study, it's tough to tell if nintedanib was in fact effective when it's being overshadowed by autoimmune ILDs, which make up about a quarter of the patients that were involved. But due to the fact that the baseline characteristics were very similar, and there wasn't any statistically significant differences there, I lean towards putting this as a strength for the external validity of the study. For limitations, this was an intention to treat study, which is not what you want in an RCT. Once these patients were randomized, they were analyzed. Funding bias may have been present, as Boehringer Ingelheim was the funding source, and they're also the company who created nintedanib. Performance bias is present due to the 153 different sites that participated in the study. Transfer bias is also present in the study due to the disparity of discontinuation of the treatment among the two groups, most likely due to adverse effects of the nintedanib. So of the 332 versus 331 people in the nintedanib and placebo groups respectively, 80 people prematurely discontinued the nintedanib, and only 49 people did the same on placebo. The author's conclusions, very similar to the results of the primary endpoint. Nintedanib treatment was, across a broad range of ILDs, did exhibit efficacy, and it showed itself to decrease the rate of decline of FVC in patients with these PF-ILDs. My conclusions: nintedanib has shown clear efficacy in treating PF-ILDs of all types versus placebo, but based on the additional analyses and the secondary endpoints that they found, I would say that there is not much benefits in quality of life and mortality, and that is something that should be looked into and taken into consideration when you're looking at the efficacy of this drug. Obviously, it's efficacious in FVC rate of decline, but not as much in mortality at the end of the day. The impact on practice, like I said in my conclusions, it was very effective in displaying the efficacy and decreasing the rate of decline, but at the end of the day, quality of life and mortality, not much benefit there. So I hope you're able to form an opinion based on what I presented to you today. And if you have any questions, feel free to email me. Thank you.